Tests and testing for COVID-19. Testing has become an important topic during the COVID-19 pandemic, and we should all be informed about the pros and cons of available tests, their utility, when it is important to institute testing and why, as well as being able to interpret test results in order to benefit our patients and healthcare professionals that work in an environment where patients' procedures generate aerosol, and of course for the benefit of public health and public health policies. Timely and accurate COVID-19 laboratory testing is an essential part of the management of COVID-19 for slowing down the pandemic, for supporting decisions on infection control strategies and patient management at healthcare facilities, and for detecting asymptomatic cases that could spread the virus further if not isolated. Furthermore, testing can also facilitate contact tracing to identify individuals that have had contact with an infected individual. There are important questions surrounding testing that need to be answered. For example, what types of tests for COVID-19 are available? What information will a specific test provide? How are test results interpreted? How reliable are these test results? What are the implications of a test result? Why do we want to perform a test in the first place? And what do we intend to do with these test results? There are two general types of infectious disease tests: those that test for the virus itself, the antigen, and those who test for the body's immune response to the antigen, meaning antibodies. So we have viral tests and we have antibody tests. Detection of viral RNA generally indicates active, ongoing infection and suggests infectiousness, especially during the early course of the infection. It is not clear, though, if presence of viral RNA at the later stages of the infection is synonymous with virus being capable of causing an infection. An increasing number of companies now offer different types of COVID tests that can be divided according to what they are trying to detect and the technique used to detect the presence of the virus or antibodies. The tests to detect viruses include techniques such as real-time reverse transcription polymerase chain reaction, or RT-PCR. With the aid of a special swab, samples from saliva, the nasal and oropharynx, as well as sputum, are collected to detect the presence of viral RNA. Other methods are available to collect respiratory and deep airway samples. There is also something called reverse transcription loop-mediated isothermal amplification, RT-LAMP. RT-LAMP also detects presence of viral RNA, and this technique is more robust and quicker than the regular RT-PCR. There is also clustered regularly interspaced short palindromic repeats, or CRISPR's technique, that can be used. The essence of CRISPR is simple. It is a way of fixing a bit of DNA inside a cell. Although not yet in clinical work, CRISPR-Cas12 and Cas13 based diagnostic tests for SARS-CoV-2 might offer advantages over current technologies. Now, CRISPR-Cas12 and Cas13 provides for high sensitivity, can detect as few as 10 gene copies, also very high specificity, portability, all easy readouts, and very low cost, up to around a few dollars, as well as speed. We could actually get the results within 45 minutes. By the way, the Cas12 and Cas13, those are specific proteins used to cut specific genetic sequences that are detected with this type of technology. One of the first machines available for testing for this virus outside a healthcare setting was produced by Antibody, and this machine that you see here in front of you weighs around 6.6 pounds or 3 kilograms and has a throughput of around 50,000 tests per day. And this technique used in this machine could actually detect a positive test within 5 minutes and a negative test within 13 minutes. On the right-hand side is a depiction how this technique works within this specific Abbott test that I showed you in the previous slide. First, an upper respiratory tract swab collects mucus to sample for the testing. Second, the sample is mixed with reagents which break open the virus and release its genetic material, in this case the viral RNA. The reagents recognize a unique section of the coronavirus genome, and while ignoring other viruses of similar strains. And then the virus genome is replicated from a few target molecules up to a billion, and that's what amplification means, making the virus more detectable. And lastly, this can then be detected in the machine that Abbott has created. Another company, Cepheid, also has a test that can be used outside healthcare system, and this test can provide a rapid detection of SARS-CoV-2 in approximately 45 minutes. A couple of days ago, on April 13th, Rutgers University announced that they have now received approval or emergency use authorization from FDA for a saliva-based test. Now, this test also looks for nucleic acid from the virus itself, and it can use samples from the oropharynx and from the nose and even from saliva. Negative results do not preclude presence of the virus and should not be used as a sole basis for patient management decision. Negative results must be combined with clinical observation, patient history, and epidemiological information. So this test, as well as other tests that test for the virus, needs to be used in combination in order to get a more accurate information about the patients being positive and negative. And the reason for this is that these tests may have a fairly high false negative rate, and I'm going to speak more about that later on. Collection of saliva specimen is limited to patients with symptoms of COVID-19. And that's important, meaning we cannot use this test for asymptomatic patients. And the results will be available in 24 to 48 hours. Now, there are also tests that can detect antibodies. And there are several different types of these tests available, and they can be arbitrarily divided into three different classes. Rapid diagnostic test, or RDT, that give a result within 10 to 30 minutes. Enzyme-linked immune sorbent assay, or ELISA test, that will give a result within 1 to 5 hours. And neutralizing assays that will give a results within 3 to 5 days. It's important to realize that these tests will provide you with information about the presence or absence of antibody, but they will not be able to tell you if these antibodies will provide immunity or not. Schematically, this is the way it works. The antigen, in this case the virus that you see in the middle of the slide here, have these spikes on the outside envelope of the virus. Antibodies will recognize these spikes and attach itself to some of the regions inside these spikes. If these antibodies attach itself to a region that is responsible for attaching the virus to a susceptible cell, these antibodies will be able to prevent the attachment of the virus to the cell. Obviously, if attachment occurs, the viral RNA is going to be spilled into the cell and then use the cell's replication capacity to produce more viruses. So some of these antibodies will be able, hopefully, to attach itself to the region of the spike that will prevent attachment of the virus to the cell, and therefore we're not going to have any more viral replication. The first of these antibody tests that got approval from FDA came from Cellex. This was a rapid diagnostic test with a sensitivity of 93.8% and a specificity of around 95.6%, and I will talk more about sensitivity and specificity a little bit later. Another test recently approved by FDA comes out of Ortho Clinic Diagnostics from Rochester, and a third one comes from ChemBio Diagnostic System, also approved by FDA for antibody testing. You have to be very careful though. There are approximately 70 different tests that are being sold today that may claim that they actually have FDA approval. There are only 3 tests that have FDA approval. So be aware for people who are trying to sell you tests that have not been approved by FDA. Sampling is very important. And there's a difference between sampling antibodies and sampling the virus. If you sample the virus, it depends on the person's viral load and the anatomical place from where the sample is collected. And it also depends on the technique, meaning how the sample was collected. Unfortunately, we have seen some problems with collecting samples to detect viral DNA, specifically from the oropharynx, where the person performing the test may have not gone deep enough in order to reach that specific anatomical site. Serological tests, on the other hand, will test for antibodies in the blood, and they are of course uniformly distributed in the blood, so one drop of the blood will give you an indication if antibodies are present or not. They're not dependent on any specific anatomical site. So why would a COVID-19 test fail? Well, the patient may be in an early stage of the disease with a viral load that is too low to be detected. The patient may have no major respiratory symptom, so there could be a little detectable virus in the patient's throat, nose, or in sputum. There may have been a problem with the sample collection, meaning there was very little sample to test. There may have been poor handling and shipping of the sample in the test. There may have been technical issues inherent in the test. For instance, viral mutation might have occurred. And for these reasons, the WHO suggests that these issues should be taken into account and that for some people, tests should be carried out several times. While PCR tests and similar tests can detect the presence of the virus, serological tests can detect past infection and possible immunity. But it's also important to realize that the timing of doing this test have a great impact on the test results itself. This graphic depiction shows approximately when we can expect to find the virus, viral RNA, IgM, and IgG during the progression of a patient's infection. The virus can be detected very early on, and then it wanes over time until the patient convalesces and the patient is healthy. The IgM are the earliest detectable antibodies, and they can appear around 7 to 10 days from the time of infection, while IgG, on the other hand, will take a little bit longer to be present in the blood, and we can expect them to be detected after around 14 days. IgM will wane over time, while IgG will remain for longer periods of time. And when we are looking at immunity, it's the IgG we are looking for. It is thought today that these IgGs may possibly provide immunity up to around a year, could be even longer, but more information obviously will be available. Another thing that is important to realize on this slide is what we call the window period. The window period is the time from infection until the body's immune system have started to produce enough antibodies to be detected in the blood. Meaning, during this time period, during the window period, even though you may be infected and infectious and asymptomatic and have presence of the virus, an antibody test will not detect that you have been infected. So if we now use antibody tests for screening, which we can do and probably should do in the future, they will not be able to detect if someone is infectious in the earliest stages of the infection. How long time does it take for these antibodies to develop? What is the window period? It is unclear. This is one study that was published a couple of weeks ago that looked at a specific cohort of patients from China, and these researchers found that total antibodies develop within the first 11 days, meaning IgM, IgG, and some other type of antibodies. Day 12, IgM could be detected. At day 14, IgG could be detected. Now the window period, though, was very interesting because the presence of antibodies was less than 40% among patients within the first week from the onset of the disease. But after 15 days, there was almost 100% presence of the antibodies we are looking for. So according at least to this study, and there will be many more in the future, the window period could be estimated to be approximately 7 to 11 days. We have available to us PCR, IgM, and IgG, and a combination of these tests will help us much better interpret where a patient may be throughout the infection. If I look at the first row, PCR positive, IgM and IgG negative, this may be the possible window period where the virus is present but the body has not produced detectable antibodies yet. PCR positive, IgM positive, IgG negative is a sign of an early stage of the infection. PCR positive, IgM positive, IgG positive, active stage of the infection. And then after a while, IgM will wane and PCR will remain positive and IgG will remain positive. And now we're probably in the later recurrent stages of the infection. We could also have a situation where the PCR is negative and the IgM is positive and IgG is negative. Well, this, according to IgM, would be that we are in the early stages of the infection and we should have virus present that could be detected. So most probably, this is a sign of a false negative PCR results. We can also have PCR negative, IgM negative, and IgG positive. This represents a convalescent stage of the infection where patients have recovered from the initial infection and the disease. PCR negative, IgM positive, IgG positive, again, most probably false negative PCR, but the patients are most probably in the active and or in the recovery state of the infection. We're going to hear much more about the antibody test and testing, and there are many reasons for this, because these antibody testing can be used for many different things. Number one, we can verify that vaccines are actually working. Vaccines are based on stimulating a patient's immune system to produce antibodies. So after having administered a vaccine, we can test for antibodies to see if the vaccine was actually working. We can also use antibody testing for contact tracing. We can help to inform public policy. And we also have to realize that antibodies reveal evidence of a previous infection, so that will give us enough information in order to find out what the prevalence of COVID-19 might be in the population as a whole. There are important terms that we use in testing that are essential in order to be able to interpret the test result correctly. They are sensitivity, false negative, specificity, and false positive. Sensitivity is the percentage of individuals with a disease that will test positive for the disease. False negative, individuals with a disease that will test negative for the disease. Specificity, the percentage of individuals without a disease that will test negative when testing for the disease. And false positive, individuals without a disease that will test positive for the disease although they don't have the disease. Let me show you graphically how that might look like and how we actually calculate sensitivity and specificity. Here we have a 2x2 grid that illustrates how sensitivity, specificity, false negative, false positive results can be calculated. In the first column, under disease positive, in that column we have all the cases of individuals with a disease. In the second column, disease negative, is the column for all the individuals that don't have the disease. In the first row are those that are going to test positive when testing for the disease, and the lower row depicts those individuals that will test negative when tested for the disease. Sensitivity is calculated by dividing the true positive cases by the true positive and the false negative cases, and specificity is calculated by dividing the true negatives with true negative and the false positive cases. Here's an example where we have 100 individuals with a disease and all of them test positive, and then we have 100 individuals without a disease and all of those test negative. Obviously here we have 100 true positive cases, no false negative, and sensitivity will then be 100%. The specificity is also 100% because we have 100 true negative cases and no false positive cases. Something else you're going to hear about also is the accuracy of a test. Now the accuracy of a test is calculated based on the true positive plus the true negatives in the numerator divided by all the true positive, false positive, true negative and false negatives. In this case, the accuracy of the test is 1.0. Here's another case where we have 100 individuals with a disease, but 2 of them don't test positive for the disease when we test for the disease. So here we have 98 out of 100 patients with the disease that are positive. So the true positives are 98, the false negatives are 2, and the sensitivity becomes 98%. The specificity didn't change, we still have the specificity at 100%. Now the accuracy of the test is 0.99, still a very accurate test. Another example could be that among the patients without the disease that are being tested, 10 of them actually test positive for the disease. So now we have 90 out of 100 patients without the disease that test negative, so the true negatives are 90, but we have 10 patients without the disease that test positive, and those are false positive. So the specificity in this case is 90%. The accuracy of this test is 0.94, still a very accurate test obviously. Now, if we want to get involved with mass testing, there are various strategies we can use. One first started in South Korea, and one that has since been emulated in many other countries, is a drive-through. The advantage of such a setup is the speed and the lack of direct contact between persons being tested and healthcare personnel. But the downside is, of course, that in order to use this type of strategy, you need to have access to a car. And there could be individuals that don't have access to a car, especially disabled persons. Let's use an example of a test with a sensitivity of 95% and a specificity of 95% and see how we would interpret results from mass testing. Our first assumption is that we want to test 1 million people. And the second assumption is there's a 5% prevalence of disease, i.e. among the 1 million people, 50,000 actually have the disease. A sensitivity of 95% means that out of the 50,000 truly affected individuals, 47,500 will have a positive test, but 5%, 2,500, will have a false negative test. A specificity of 95% means that out of the 950,000 non-infected individuals, Remember, we started out with 1 million individuals and 50,000 of those were infected, which means we have 950,000 non-infected individuals. 95% of those are going to have a negative test, which means 902,500, but 5%, 47,500, will have a false positive test. Now we have a conundrum. We have 47,500 people with a positive test that are infected, and we have 47,500 people with a false positive test. Unfortunately, with the same number of true positive and false positive individuals, there is only a 50% chance to determine who is truly positive among all individuals with a positive test. And this is something we need to consider if we do all this testing. So if someone comes back with a false positive test, are these individuals now going to be hospitalized? Are they going to be isolated? Are they going to be in quarantine? Or are we now going to demand further testing of all the positive results in order to find out who is truly positive and who is not? Something else that is very disconcerting is that we're going to have 2,500 individuals with false negative tests, meaning we're going to tell 2,500 people they're not infected. And if we tell them they're not infected, yet they are infectious, what is the possibility that these individuals now will spread a disease to other individuals? So therefore, using antibody testing is very good, but we have to know the sensitivity and specificity of the test in order to know what to do with the results. So what could be then the consideration for implementing testing for COVID-19 in a dental setting? Many oral healthcare providers have considered performing COVID-19 testing of their patients. Although this could be a good idea, there are several questions that need to be addressed before starting such an initiative. Here are 8 essential questions that I believe must be answered before instituting any testing for COVID-19 in a dental setting. What is the intended use? Meaning, what are you going to do with a positive and negative result? What is the clinical decision that will be enabled by the test, and in which patient? Who will be tested? Who will perform the test? Which samples, nasal or pharyngeal swab, sputum or blood, are going to be used? What is the minimum acceptable sensitivity and specificity? With whom will you share the test results? And what will you be able to tell the patient about the result, which of course is a very important consideration. Other important considerations include that if we start testing in an oral healthcare setting by dentists, we are actually triaging and screening because we cannot diagnose the disease. That is not within our scope of practice. Information and communication technologies to capture and report data for reporting to other stakeholders is needed. And I'm not sure yet that we have this type of technology in dental setting. For instance, if you find an individual that is positive, who should know about this? Other healthcare workers? Should we be able to communicate it with some mobile type of health device? Should public health officials be informed, CDC, WHO, and so on and so forth? If we do implement testing, it should be quick turnaround time, not more than 15 minutes to an hour. We also need availability on confirmatory tests. As I showed you previously, there are a lot of false negative results as well as false positive results. And understanding and interpretation of test results are absolutely essential. And the test should be preferably used by minimal trained users in outpatient settings. Although I may have left you with more questions than answers, I hope I have at least highlighted issues that we need to contemplate when evaluating tests, interpret test results, and consider implementing testing in a dental setting. Thank you for your attention.